All right, hello and welcome everyone. We'll just wait a minute or so before we get started so that everyone has time to enter into the session. So as we do that, I'd just like to thank everyone for joining us for the second time this week for our masterclass, our Primary Care Masterclass in Sport and Exercise Medicine and Musculoskeletal Health. It's been a fantastic week so far, and we've really been fortunate to have two experts in the field, and I would say the two leading experts on physical activity prescription worldwide. Just an honor for us to be able to learn from your insights, and thrilled to be able to introduce our second presenter today. Before I do that, I'm just going to go through a couple of housekeeping items. And the first is that we'll start with a land acknowledgement first. So I'm here at Western University in London, Ontario, in Canada. And here we acknowledge that this is sacred land upon which we are privileged to live and work. We recognize the deep connection and longstanding relationship between Indigenous peoples in the land of Southwest Ontario and of London. And we acknowledge the Anishinaabe, Haudenosaunee, Lunapewak, and Chinantan nations whose traditional lands we are gathered upon today. We are deeply grateful to have the opportunity to be in this place. And with that in mind, I'd just like to mention a couple of final housekeeping items that most of those who have been attending these sessions so far would be well versed in, but essentially we're going to be using the Q&A function on Zoom today instead of the chat function for answering any questions or comments. So please use that throughout the session. Generally, we ask that the speakers finish their talk, and then we'll open the floor for questions at that time. If you're starting to write something down or you're curious as to other people's questions, it's great to have a look in that chat, and then you can always upvote other people's questions if you like them. That will increase the priority that we answer them in, so that we can answer them in those priority sequence. This session is being recorded today, and those that have registered, particularly for the CME, welcome today and we'll be in contact with Kristen Riley after the session, and but those can access the recording as well following the presentation. And so today, so I'm speaking now, but I'm very soon going to be turning over the mic to Dr. Mats Börjesson, and we will have him speak for the next 40 minutes or so, and then we'll open it up for about 15 minutes of Q&A. And I do want to thank Dr. Sadia Jan and Eric Wong, who is part of our scientific planning committee, and so this masterclass was developed with input from them. So I have the pleasure of introducing our speaker today. This is a speaker, Dr. Börjesson, who I've been just honored that you're here today, because it's really been remarkable in terms of your career, your advocacy, and your leadership in this particular topic worldwide, and as well as in other areas of athlete health and exercise and health as well. Dr. Matt Börjesson is a physician, professor, and head of the Center for Lifestyle Intervention at the University of Gothenburg and the Sahlgrenska University Hospital in Sweden. He's a specialist in internal medicine and cardiology whose research interests and expertise include sports cardiology and physical activity for health. He's chaired numerous international working groups, including the Task Force of Physical Activity and the WHO Network Health Promoting Hospitals. And he's here today to continue Tuesday's discussion about providing personalized physical activity prescriptions. So thank you, Mats, and I will turn everything over to you.
Thank you, Jane, and thank you everybody for inviting me. My talk today is about physical activity prescription in primary care, providing personalized advice. And being a specialist in internal medicine and cardiology, we still do a lot of research in physical activity prescription in the primary care setting. And I'm from Gothenburg, as Jane said, which is similar in climate to Canada, I would say. I also love ice hockey, by the way. There is a potential bias, and talking about physical activity, there is some disclosure about financial support for all, and for me, you can see it down below. and also have some relationship with financial sponsors, but nothing in regards to health or physical activity, I would say. I would just start with teaching you a word in Swedish called lagom. Lagom means not too little and not too much. And this, regarding physical activity, was something that Hippocrates already knew 400 years BC. And this is actually the core of the talk today. Physical activity, not too little and not too much. And this is what we have to think all the time and keep in mind when we prescribe activity to our patients. And first of all, a very old slide. I have to apologize for that. It's from the Center of Disease Control 20 years ago. But I would say it's equally important today, saying that lifestyle behaviors contribute to at least 50% of our total health, meaning that lifestyle behaviors will be and is important now and will be even more important possibly in the future for our health. And a more recent slide, though, coming from a paper we just published a few weeks ago in the British Journal of Sports Medicine, saying that your fitness level, this was done in over 1 million Swedish male conscripts at the age of 18 to 19 in military conscripts. They did a fitness test on bicycle, and their fitness levels at that age was associated to the risk of cancer during a mean follow-up of 33 years. And then the big volume and big number of cases, we can see that we can also look at different kind of cancers, which is a new thing. And we can see that many cancer forms later in life are associated with a lower fitness level already from the age of 18 or 19. And physical inactivity is a problem. According to the WHO, around 27%, some say 1/3 of the population are insufficiently active, and that means that 75% then is active enough. And is this really true? Is the problem even bigger, perhaps? And let's remind us that in Canada as well as in Sweden and globally, the WHO recommendations are, and also national recommendations, I would say, is 150 minutes of medium intensity physical activity per week. And is 75% fulfilling that? Maybe. And remember then that these are questions. In Europe, we have something called a Eurobarometer, and this is a few years ago that many countries in Europe were asked, do you exercise? And this is even tougher question, I would say. But in Sweden, most people of all these European countries answered that they were doing exercise or sports. There was 91% who said they were doing that between the age of 20 to up to 80, which I don't believe, because it's a very high figure. But these are the figures we get when we ask people and in questionnaires and in different settings like this telephone interview. So if we look at the official statistics from different countries, you usually have what people are referring to themselves, self-assessment. And these figures, I would say, is much too high. So what do we know then? Yeah, we know that fitness in middle age is declining. This is a study from 30,000 Swedish people in the big SCAPI study, which is a major study that looks at everything, I would say, but also physical activity in terms of accelerometer and fitness with submaximal exercise test. You can see that all these individuals are between 50 to 65 years old. And we can see that the 50 years old are more active or have higher fitness than the 55-year-olds and a higher fitness than the 60-year-old. But you can also see here that the yellow dots, the ones who are most physically active, actually don't decline as much. And you can you can actually be have a higher fitness if you're active at 60 than you have if you're less active at 50. So the decline is not only solely due to age, is also because you are less active. And we also know in our country that the fitness level of the working population is declining between 1995 and 2017, and it's actually most have declined the most in men, in the people from lower socioeconomic classes, and also in the young population. So this is very disturbing for the future. So could we have more objective measures using accelerometry? I'm sure many of you use that in clinical studies now, and I know Jane does. And do you use accelerometry to have a more objective measure of physical activity level? You know, accelerometers are more like a very boring step counter because you can't see anything on them. They are like inert, but you have to make them pass different data processing and calibrations and so on. And then you can get values for how many percentage of the waking time you are sitting or laying still, or be low intensity activity, medium, and high intensity activity. But there are also problems with accelerometry I'll come back to. So using that accelerometry in a 30,000 Swedish population, we got good measurements from almost 28,000. And you can see in the pie chart here of awakened time, this is the 16 hours we are awake, you can see that we sit almost 60% of the time. And we have low intensity activity for most of the remaining part of the day. And as you can see here, none of these will actually count into the 300 minutes or 150 minutes, I would say, a week. But the little gray area here is in summary of the moderate intensity, high intensity, and very high intensity activity. And this is in middle age. So I can already now say that it's even worse in the young people from other studies. But we can also see here that the risk factors for sitting much and being less active is male sex, higher age, high BMI, which is a very important risk factors, shorter education, and a smoker. And this is not something you know, we already know this, but this is very important information that we have to target these groups especially. But finally, how many are then physically active enough? To answer that, you have to know you cannot use the algorithms that are usually used for actigraph, for instance, or any other accelerometer, because it will underestimate some people and overestimate some, because medium intensity activity means different to a person depending on their fitness level. So you can see on the figure here to the right that if you use the algorithms, then the cutoff for low intensity activity is 200, and then you have 600 for medium intensity, etc. But in reality, all these algorithms are skewed, and you can see on the colored charts that you have to do much more activity if you have a higher fitness than if you have a lower fitness. Meaning that walking could be low intensity for a well-trained individual, medium intensity for a medium-trained, and high intensity for an old person. So meaning that in that sense you can calculate, if you have both the fitness level and the accelerometers of every person, you can have individual cutoffs that you can really count who was doing medium intensity activity for 150 minutes a week, and the answer was 21%, not 72% like the WHO, or 67% or 91% as in the Swedish questionnaire. It was 21%, and this figure much more illustrates what we in clinician thinks that's a true figure. So we are physically inactive, and we are less active than we believe, I would say. So what are the barriers to increase activity and work with lifestyle behavior? We did a survey on the Swedish Society of Sports Medicine, did a survey looking at healthcare personnel and asking them. And the 5 major topics they come up with, reasons for not, or barriers for not doing a lifestyle intervention, was that we need more research and evidence. which is questionable, I would say. We have a lot of research and evidence, but we do need education how to do it, like today. We don't have the money at the time. That's a very relevant thing, I would say. We're all busy. Prevention needs to figure out how to work within the existing medical system. That's structure support, and I think that's a really major thing. It's hard to getting people to change, which is also, it's more like people have a difficulty of changing lifestyle, which is true. And it's just overwhelming. Again, structural support. But the most important factor they didn't mention, and I believe that may be the most important of all, or at least the very important one, that's our own motivation to use this. And we did a study at the Karolinska Hospital in Stockholm when we look at the thoracic department and all the personnel there and their work with lifestyle behaviors. And they thought it was very important to work with this in general, very important for their own practice, but they did very seldom ask the patients, as you can see, and counsel to even less extent. How come there is such a gap between our interest, we know it's important, and that we don't do it? And the answer they gave in the questionnaire was that clear routines are missing, clear goals missing, and support from management are lacking. And I think maybe all these points are really valid. So what does the patient think? Interestingly, some of us don't prescribe and talk about lifestyle behavior because we think the patient don't want that. On the contrary, I would say, at least in my country, 28% says that of patients that physical activity is the most important lifestyle factors to change. And this is the real bombshell down below here, that they say that, okay, we have a personal responsibility for being physically active, but also healthcare system has a responsibility to help me increase my level of physical activity. First you think, oh no, that's your responsibility, right? But then you realize that what they really are saying here, the patients, is that we have to help them. They are reaching out for us to help them, to emphasize the importance of activity in our counseling, to give us guidance. How active am I? What should I do? How can I do it? And they need us to bring it up and to emphasize it. So in a way, they give us responsibility for the change. Even more so in my country, the patients don't think we deliver that. So we don't have to be afraid of talking lifestyle. I think the patient's message is clear. We want you to talk about it, and you don't do it enough. So to combat lifestyle-related disease, we need to address lifestyle behavior. It's clear and simple. And therefore we need methods to increase physical activity for those being insufficiently active in healthcare. And we need evidence-based methods. So, I mean, in the old ways, in the Hippocrates days, I'm sure they used general advice. I mean, and we did up until recently, and we still do, right? We say to people, okay, and then you be a little more active and stop smoking. The problem with giving that advice for activity is that if people exaggerate or overestimate their own activity, like we can see in questionnaires, they are less likely to change because they think they are active. And by the way, they don't think they eat too much, perhaps. So the thing is that we have to really help them and give the more advice than general advice. If we put on additional support that shows that they actually are less active in terms of pedometers or diaries and follow up everything, both in diet and physical activity, for instance. It's easier with smoking because then you can just say stop, right? But then it increase the yield. Then you will have more success. It will actually increase the lifestyle behavior change compared to general advice. And again, general advice is not useless. It's much better than not saying anything, but even better to add additional support. Then comes more complex models like the exercise referral schemes, which is used in many countries. And mainly, or in summarizing this, the doctor prescribes activity, the patient are referred to exercise specialist and do a training period at the facility for 8 to 16 weeks typically. The problem with that is that most of the time the patient goes back to his or her or normal activity level, if it's activity we talk about after this session. We don't change the lifestyle behavior so much. We have another take on this called the exercise on prescription model, which is another example of a personalized advice system, which differs in key components compared to the exercise referral schemes. We know from earlier studies, and this is a busy slide, so don't care about the figures here. We know from earlier slides or earlier studies that we need individualized programs, and we need to target groups with lower resources, for instance, and which have a much more difficult setting to be active in, for instance, if we're talking activity. We also know that we need support from a network around us to be successful. These are some of the things we know from earlier studies. We know more than that, but just to give you some examples that we try to build in many of these features in a Swedish physical activity on prescription model, and I give you the key components and also maybe differences to what we're used to maybe in Canada or in other countries. First of all, the Swedish physical activity on prescription model is backed by national guidelines, and I think that alludes to the support from above, from the national guidelines, from the authorities, and thereby the head of departments and head of regions, etc. So we have national guidelines that says that we should use evidence-based methods to increase activity, and physical activity on prescription is such a model, and this is in our national guidelines. I'll come back a little bit to that. So it's in the National Bureau of Health and Welfare guidelines that discusses not the use or the usefulness of lifestyle behaviors, but gives an overview of the methods we should use to affect tobacco use, inactivity, alcohol use, and food habits. So these are the recommended treatment options and also risk groups and priorities. And this was published in 2011 and updated in 2018. And now it's going to be updated again, I think, next year. So we have the guidelines behind us that these are the methods we should use. And looking at the guidelines regarding insufficient physical activity in patients in healthcare, the things they lift in the 2018 recommendations is counseling with individualized written prescription, and counseling with a pedometer. And that means that the physical activity on prescription is actually highlighted as one of the methods we should use. They're not saying that we should not use simple advice when that is possible, but one of the preferred methods is actually the physical activity on prescription. That will help us a lot to have the authorities behind this. Another feature that we have in the Swedish PAP system is that it's based on evidence-based recommendations, meaning that we have a reference book telling us which kind of activity, type, intensity, and so on, and frequency, which is most useful, most evidence, I would say, to have effect on different diseases. And this is called the FYS book. The FYS book is alluding to, I would say, or a complement to the book on pharmaceuticals, where you have the indication for the pharmaceutical and also the mode of action. You have the dosage, and you have the side effects and contraindications, and similar we have done with the physical activity for up to 39 indications. This book was first published in 2003 in book form and has been updated, and this is the latest version, 2021. The green version, two versions back, is published in English and is available full in online. But I think that doesn't matter which book you use. I don't think it's a good idea that we should produce a book in every country. We could use the same, because it's the same evidence we use, but you have ACSM guidelines in North America and Canadian guidelines, I think. So use a reference book with evidence-based prescriptions which for each disease. which is a starting point. I come back to that. And this is on the left, there is the first book, 2003, and then the book has been published, actually translated to Vietnamese, Norwegian, English, and the latest version you saw being orange. So this is the story of the first book, and it took like 20 years to get to the position we are now. So this is just one thing. The book doesn't help if we don't have a system. Another feature of the Swedish PAP system is that it's individualized, meaning that not one size fits all in different aspects. And therefore, again, the prescription or the ideal physical activity for, say, osteoporosis or depression or hypertension must be individualized. You use that as a starting point from the first book, but then you have to individualize. And I think this is the key. And that we must be more individualized. We don't ever use one size fits all for diuretics or hypertension medications. So this is the same here. And we do counseling which are individually tailored. How do we base that individual tailor? Yes, we have the patient's health status, the diagnosis, of course, but also the level of function, the previous and current physical activity level of the individual, the readiness to change, motivation, self-efficacy, what is the patient interested in and what may be possible to do, environmental support and resources and economy. All this should be taken into consideration in a patient-centered or person-centered counseling. So not one size fits all, and it's very person-centered. And of course, the individual disease and background disease is the key, but it's much more than that. You can have concomitant diseases, for instance. And how do we then go from the ideal dose, so to speak, in the first book to the optimal dose for each individual? You have to consider individual factors, starting with the ideal dose. For example, for hypertension, and then you have to discuss is the risk profile of the individual, because high intensity activity is recommended for hypertension, medium or high intensity aerobic activity, but high intensity activity may not be suitable for an individual with severe coronary disease. So then we have to adjust the prescription, also according to medications and the fitness level of the individual, meaning that medium intensity activity for a 50-year-old is totally different from a 25-year-old elite athlete or a 90-year-old at a nursing home. The motivation again and other diseases. Maybe you have a disease that contraindicates just the kind of activity you want to do. Maybe we have to do additional testing and risk stratification, and then adjust the prescription to the optimal dose for the individual, not necessarily the maximal dose, exactly like we do with the diuretics or beta blockers, etc. The short excursion here then, the activity paradox. Take, for example, we should prescribe activity to people, and if you look at the great number of people like this running, we know that regular physical activity has multiple health benefits, but we also know that high intensity activity might be associated with an increased risk of adverse events, especially if you have an underlying disease, and that may also might be subclinical cardiovascular disease, because atherosclerosis is progressive, and this is a very nice slide we put forward a few years ago in a book and a paper. So the sex of the individual and the age remains the main drivers, the main risk factors. Sometimes we forget that. We sometimes see reports of 70-year-old totally healthy individual and male, and if you are 70 and a male, you will have to a great certainty underlying coronary disease, as shown by this study, where we again go back to Scapi's study, where also they did CT angio on 30,000 middle-aged people. You remember they were 50 to 65-year-old. And you can see in yellow highlighted the occurrence of coronary sclerosis in asymptomatic people and the normal population. If you are a man, 60-year-old, 68% have evidence of underlying coronary disease. And if you're a woman, 60 to 64, 40%. So this is very common with underlying disease. Of course, that could be a risk then. And we know that if you, after a heart attack, this is the study by Paul Thompson and Paul Williams, saying that, okay, the more you are active act after a heart attack, and the less the risk, up to a certain point, and then the risk goes up. So there is a U-shaped association, and this U-shaped association in young, healthy people is no problem at all. But in older people with a high risk, this U-shaped curve is very important to identify the nadir, the ideal activity. And to do that, to be very short, I would say if you want to do high intensity sports, you have to consider both the anatomy and the function, meaning that we have to know the anatomy of the coronaries, but also the function, meaning that you have to do a stress test. And this was a study we published last year in Trends in Cardiovascular Medicine. To summarize the European guidelines on this, in sports cardiology, and you have similar guidelines from US, which is close to you. And I would say that yes, we encourage regular physical activity for people with underlying coronary disease, but if you want to do competitive or high intensity activity, you should restrict that to those with low risk of adverse events, and to know that you have to do a stress test. I'm just saying this to give an example of the prescription needing to be very individualized if you have an underlying disease. Number 4 of the topics is that all licensed healthcare personnel can prescribe, and which is not so in many countries. It's not that, and we think it's a very big advantage that in a team setting, multidisciplinary team setting, personnel other than the doctor can also prescribe activity according to their knowledge, of course, and their underlying responsibility in a team setting. There's always a responsible doctor, of course, but that also increases the yield. We think number 5 here, that the duration is not set. We don't send anybody for 8 to 16 weeks of training sessions. We want behavior change for life. And that means that you as long as you are in primary care, for instance, after you've been to hospital, you should follow up your lifestyle behaviors and try to continue to change that if it's a physical activity on prescription you have got, for instance. The number 6 is that the follow-up is structured, meaning that you discuss with the patients how to follow up, and you remember to ask the next time, and really to follow up and change your prescription perhaps as the fitness increases or other things creep up. Diseases and medications will come, etc. Another thing is that it's also the method, and not only physical activity, is evidence-based. And we talked in the FIS book that was the evidence for physical activity being effective for different diseases, and what is the level of evidence for recommending physical activity for hypertension or coronary disease or arthrosis, and which type of activity is most supported. But that's one thing. The other thing is the method. The method we use for changing behaviors, that also has to be evidence-based. And the Swedish physical activity on prescription method has been subject of 6 at least now PhD theses in Sweden and numerous studies. And in summary, you can say the adherence is at 6 months is equal to medications. We have shown effect on physical activity levels up to 24 months. And I will show you even more results from a 5-year study soon. There has also been RCTs, so metabolic parameters and so on, and we have discussed also in those who are failures if you can add more thing to the physical activity prescription and get them to be active, and that's also been found. So there's at least 60 papers on the Swedish PAP model, and it has been summarized in a systematic review in British Journal of Sports Medicine a few years ago, showing that yes, there is moderate evidence at least that physical activity on prescription model will increase physical activity in those insufficiently active. And I think that's really important to know that we have an evidence-based method. I think there might be better methods, in the future. And I also think that we need to evidence-base all the activities and go from small pilot studies to really systematic analysis of the methods, not just the activity itself. So I'm glad to present this to you. It's a pretty recent paper we published on the 5-year follow-up. For me, it's the longest ongoing trial of physical activity and prescription. It's done here in Gothenburg and headed by Stefan Lundqvist, who is a PhD student of mine, former. And we can look at the effect of physical activity on prescription staying at up to 5 years. And there is maximums, as it seems, in activity and also in blood pressure effect after 3-4 years. But that's not so bad. And the cholesterol levels seems to be continuing to decrease after that. So there is an effect up to 5 years of the model. Another point is that the Swedish PAP system is supported by governmental money. And this is also important, that the politicians put the money where the mouth is and really support the structure and the implementation of these things. And I'm sorry for this slide being in Swedish, but this is just to show you that it's true that the Swedish government had a press release in November 22 last year, and they decided to put at least $10 million into the system, which is not extremely much, but still something that can help the regions of our country to increase the implementation and work for that, and also keep the FISBook updated, etc. And also it has already been translated into eFIS, that we have a digital FIS available, which was launched last week. Another thing is that the Swedish PAP system, it's built into the normal healthcare, and this might be, of all the points I mentioned here, this might be the most important thing. And it's also took us 20 years since we started with the system. That means that all specialists are involved in this, and it's not the right of any given specialist to for instance, it's only sports medicine docs who can prescribe activity because we know activity, or physical activity experts. I don't agree on that. I think every physician in primary care or in the hospital setting, for that matter, together with a multidisciplinary team of physiotherapists or physical trainers that we do not have so much in Sweden, but together contribute to the prescription, meaning that you should have that weapon in your arsenal, being a kidney specialist or a pain specialist or a cardiologist, whatever, apart from primary care. We have a system called how is this achieved then? We have a system called the National System for Knowledge-Driven Healthcare, meaning that the Swedish Association of Local Authorities and Regions, you can see the regions of the country here, and the west is the light blue facing the North Sea, and you can see the green, which is Stockholm area, facing the Baltic. But here, the different regions of our country collaborate in saying that we have a right to have equal health in all Sweden, meaning that there is national program areas in psychiatry, orthopedics, cardiology, etc., to form national guidelines that should be applicable in all areas. Some of these national program areas are working or latitudinally across the other program area, so to speak, and one of those is lifestyle. I'm heading the national program for lifestyle in Sweden, and we include physical activity, diet, alcohol, and smoking. And our system is to remind the other national guidelines that we should include lifestyle behavior change in prevention, in treatment, and in rehabilitation whenever it's appropriate in all the other program areas, meaning that if we are successful, we get in lifestyle advice at the right place in all other program areas. And this is then these national program or programs or guidelines will include lifestyle behaviors. And I think this is actually the key to get it into everyday healthcare. So it's not a pilot study outside. I'm soon finished now, but I just have a few slides saying that the physical activity model was voted best practice in the European Union, and we actually had a teaching sessions for 9 European countries for a 3-year project, where we have the educational part in Gothenburg, and you heard Arfan Aziz the other day, and he was part of our education and came to Gothenburg for that, and we also was subject of or the system, I would say, the Swedish PAP model was subject for OECD report, which is the industrialized and democratic countries that produced their book on healthy eating and active lifestyles, best practice in public health, which is like 300 pages. 27 of those pages was spent at the Swedish PAP, which was found cost-effective, evidence-based. And I think that's a really proud achievement. But again, one method could be slightly different in other places. The important thing is that we use one of the methods and be strategic about it. So, as a primary care takeaway, finally, I think to make this possible, to have individualized physical activity prescription, it's very important to have national guidelines and support behind you, or support, I would say. Even more important is that this is maybe a result of the first one, is that this model must be part of a regular healthcare. So projects or pilot projects do not work. You have to get it into regular healthcare. That's what we're trying to do now, is in the knowledge system. The model must be scientifically evaluated and proven to work. Not just the physical activity in itself, also the model. And I'm not saying the Swedish PAP is the only model. There might be others, right? And there are others. You should have evidence-based recommendations to base it on. Could be the FIS book, could be ACSM book, or recommendations, etc. The multidisciplinary team is very important to have, and also to discuss who is the prescriber. And in my opinion, you should have a broad number of specialities to be able to do that, and you should do it in a team setting. Individualization is the key for the individual, not one size fits all. I think that's the key to reach people who have more difficult circumstances and are more difficult to reach in other ways. The easy targets we usually reach, but the ones who are very much difficult to reach, you might reach by being more and more individualized. And reimbursement you can discuss. I haven't talked anything about that, and that was tried in the beginning, and it does have an effect, but it's not long lasting as we see it. But you can certainly discuss reimbursement to doing this as for other methods. And I would also add to your takes for primary care, that takeaways for the future, that we must learn from each other's mistakes. We discussed this before we started the transmission, that we do a lot of things in different parts of the world, and we must get together and not only present what we do, but discuss the mistakes, and so we don't repeat them. And we have certainly now 20 years of experience, and we have done a lot of mistakes. And I think we should, maybe learn from each other. Collaboration is therefore needed, and we have to move away from showcasing those projects and really discuss the cores, the components of who can prescribe, who can be involved, how can we involve all specialists and not make it some specialists do that, and how do we implement it fully into regular healthcare. And finally, nobody can own this method. That's the thing that annoys me a little bit when somebody says that, oh, you have to be a sports medicine specialist, or you have to do that for safety, etc. I think it's equally important for any primary care physician to be able to prescribe, but have to surround themselves with a team so they can do it in a multidisciplinary order. And I think I think there may be some questions, and I will happy to take them. First, I would like to finish to say that to work with individualized prescription of physical activity is to truly apply personalized medicine, or rather, I would say personalized health, and that's my key. And then a small slide from my hometown of Gothenburg. Thank you very much.
Thank you, Mats. That was a fabulous presentation. I know that many of us here in the Canadian system have just probably been, like I have, wishing that we could learn so much more and collaborate, because the system and the model that you have is really inspirational, I think, to us in Canada, in the sense of and how to promote physical activity in healthcare. So thank you for sharing all of those insights. And I love one of your final takeaways there was that no one should own this method. And this is essentially what we're trying to do with this masterclass, is understand that it is really something that can be implemented at the primary care level. And many times that's the front lines, and it's probably the best place to do that. And as you said, kind of surround yourselves with a multidisciplinary team and other experts that can help support the initiative and the patient through that process. So thank you for emphasizing those, because I think they're really important for us as well, just to understand that it's all of us, it's all specialists that can be involved in this very specific aspect. We'll start off with a question from the audience, and then we may just follow up a little bit on the sense of the Swedish model, because I think that we have a lot to learn here in Canada from what you're doing. So we have a guest who's asking that individuals with musculoskeletal pain often cannot meet the physical activity recommendations due to their pain, and just wondering if you had any strategies to help them.
Yeah, I think this is a very good example on where we know. For instance, if you have musculoskeletal pain and you also have hypertension, and we should recommend your physical activity for your blood pressure, and then meaning that your musculoskeletal problems will be a barrier to that, or also that your musculoskeletal problems could be helped by being physically active. So then it's a typical example where you have to adjust your prescription and not go for the ideal prescription, or more, you go for the optimal. You start slow. There's actually lots of studies in fibromyalgia, for instance, where you can achieve the public health level of or recommended level of physical activity, but after like 3-4 months of successfully increasing the activity and listening to symptoms, etc., and you start maybe painfully slow, that the patient thinks, oh, this is too little. But we all know that people with musculoskeletal pain, or especially fibromyalgia, if they do too much, they might be in the bed next day. So right. Starting slow and increasing. So I think it's an excellent example where you have to adjust your prescription, and in that way you can reach the public or the global guidelines in a number of months.
Absolutely. Yeah, that's a great answer. And I think as well, I know in my personal experience, oftentimes patients will come with pain, and then normalizing the physical activity behavior that they can still move. Instead of potentially being, the example that comes to mind is low back pain, that people will understandably get potentially fixated on an image finding or something along those lines, and say that that's a limitation. But once they're able to understand that movement can actually help that, it's really interesting to see them in follow-up, because oftentimes they feel very empowered and enabled that they've been able to get over that and improve their pain and function through movement. So that's fantastic. Do you find that in terms of your model specifically, you'd mentioned kind of structured follow-up as being one of the benefits and of the Swedish physical activity on prescription? And I'm just curious in the sense of with that follow-up, do you have a sense of how often that needs to happen, or if patients, is it a 6-week thing? Is it every 3 months? Is it something that's individualized as well? Or
yes. Yeah. The boring answer, or in a way, is that I do sincerely think it's individualized, because I think some people need, and that's part of the dialogue, I think, with the patient. I mean, make it really simple is that I had a patient many years ago that I would never forget, because he was smoking, and I kept asking him, and in the end I didn't ask him anymore. And then he stopped smoking, and he was angry with me because I didn't ask. So I think follow up is is very important. But I do think we have to involve the patient in how often.
Fair enough.
I
Yeah.
don't think it's some need very much hands-on. Other and that should be a part of the dialogue. That's my
And
take.
do you find that it's structured with other appointments or that kind of thing, or do you find
Yeah,
that
I think it's should be part of the, as much as possible in a regular structure, and you should give it the same emphasis as other risk factors, because as for instance physical activity level, it's the same risk, the same degree of risk as a cholesterol level or blood pressure levels and so on. So we should really lift up these lifestyle behaviors to make them more heavy, so to speak, in our regular checkups.
Excellent. And do you find that with specialists, I think that's one of the key things that we've seen here that tried to emphasize, especially in our medical education, that it's really something that all specialists can be involved in, even at the hospital level. Maybe they're doing rounds in the morning and looking in on general internal medicine patients and so on. And just sparking the conversation about getting up out of bed, moving around, things like that. Although I would say that it isn't necessarily part of our professional training, either in the undergraduate medical level or beyond. Although it's starting to change a little bit. But I was just curious about how you found that that approach with the specialists in Sweden, in the sense of, do you find that there's buy-in from people other than family medicine or general practitioners? And yeah, how have you seen that evolve?
Yeah, it certainly started with family medicine. I mean, it started with family medicine, and it started for musculoskeletal, I would say, 20 years ago.
Okay.
And that was the most common diagnosis and the most common, prescriber. And but we also have a similar development in cardiac care, for instance, for rehabilitation, for rehabilitation, cardiac rehab, or heart failure training, or even after stroke, etc. So we do have the rehab thinking that you should do physical activity, right? So it's not that far-fetched to say that you can use physical activity for treatment,
Right.
also for a not severe depression or osteoporosis or arthrosis or hypertension. So I think it has creeped in that you usually do is as a treatment. We usually start from the treatment option when we talk to hospital doctors, because primary prevention, they are interested in that, but that's not their first line.
Yeah.
And I think we should sometimes emphasize the primary prevention, and sometimes the secondary or treatment prevention or treatment options. And physical activity is not just primary prevention; it's treatment.
Exactly.
So I think we should start from the treatment option. What can I gain from that if I have a cancer patient, or I think that's really important.
Right, absolutely. And maybe to finish off on a couple of the items that you brought up today. I mean, I love the FIS book. I know that when the English version was something that I've referred to often, it's a fantastic resource, and it's really kind of a one-stop place for really good evidence-based recommendations. So congratulations on such a monumental effort over the last 20 years. It certainly paid off for many of us around the world to be educated on those principles. Just in terms of the medical education part, because this was a question that came up with Dr. Asif as well on Tuesday, was that question of how do we promote or look at incorporating physical activity prescription into our medical education. So that's something that we've tried to look into in Canada as well. So just be curious about your final thoughts on that.
Yeah, I mean, first of all, I think that historically we has done a lousy job of that, in education, and I think we're doing a little better job now. But maybe we should do it, because the lifestyle behaviors is everywhere. So I think it should be a stream. It's not something you do in 1 week or 2 weeks and then it's off, right? You should bring that up as a treatment option. If we talk treatment first, prevention of course, but treatment option, either if you're doing orthopedic course or internal medicine or psychiatry or primary care. I think that it should come back many times. For instance, I don't know how many times we hear about diabetes during our 5 6 years of med school, 30 times in different courses, right? And I think that's why you learn it. So I think that lifestyle behavior should come back. That's my idea. That I think that it's not my ideas only, but that's why I think that what I think it should come back as a treatment option in all the relevant places, and it's many.
Yeah, absolutely. And so do you find that people are enthusiastic about that as well? I mean, we've certainly seen a shift from medical students being the ones that are actually the ones bringing up this fact more so than maybe established physicians.
Yes, I do think that it helps with the national system I showed you at the end, where we have these national guidelines as a thing of getting equal care in the whole country. And that's a governmental thing. They want us to have the same treatment in north and south and west, and part of that we do this treatment guidelines, and then many of these guidelines, being cancer or pulmonary disease, they will ask us how come lifestyle behavior change in, and where do we miss it, and in many times they want to have it in, but they're not really professionals in that and so on. So we have to help them get this into their so the national guidelines of pulmonary diseases includes physical activity, right? That's, I think, important. Otherwise it will be a specialized group of people outside, sports medicine docs and physiotherapists. They're outside and trying to influence, which is much more difficult. So the key is to get it into the different treatment guidelines for each relevant disease, and there are many.
Yeah, exactly. No, that's a fascinating way of thinking. And in terms of, I mean, certainly, as you say, it's really a whole system approach, in the sense that it's not just one person or one group of specialists, but it's really needing to be across a multidisciplinary approach, but also with that governmental feedback and support. And just that continuous advocacy, but I agree, it's fascinating to see, and it really is inspirational to see how the model
also with the same evidence. You in primary care, for instance, you use different treatment models for different diseases, and it should have the same evidence. You have to have the same evidence for prescribing activity. It should not be something, it's if it's effective, you use it. And I think that's part of and it is. We know that.
Right,
so.
Exactly. Yeah, that evidence-based care, absolutely, or evidence-informed. That's wonderful. Well, thank you so much, Mats. I think we're all even inspired, and I do believe that there's a lot to be gained from learning and collaborating and so on. So I really do appreciate sharing your insights on how the success of the physical activity prescription program, but also just your leadership and advocacy and insights on that. I think it's very well received on our end. So I want to thank everyone for joining here as well today. That you'll be sent an email containing a link to the participant evaluation survey tomorrow. So please take time to complete the survey, and then you'll have an option as well to indicate whether or not you need a certificate of participation. And if you click yes, you'll be directed to another link to input your email, so your evaluation remains anonymous. And you can also reach out to Kristen, who's put her information into the chat box, who is our research coordinator, to receive that certificate. And we can also email us with any questions or concerns. So Kristen's email is in the chat as mentioned. And we look forward to seeing you again in October for a following masterclass. And again, once again, it's been an absolute honor to have you present to us today, Mats. And I thank you, and I hope you have a nice rest of your evening.
Yeah. And thank you, everybody, and Jane and Kristen and everybody, for inviting me. Thank you very much.